Talk a little bit about fibromyalgia and how I see that illness and how it integrates with chronic fatigue syndrome. The most important thing to note about fibromyalgia is, I think, is that to give you a story about the fibromyalgia clinic in Charlotte, where I practiced medicine for a decade. It was a rheumatologist in Charlotte, and he ran a fibromyalgia clinic. And we tended to trade patients, but for different reasons. And his clinic was right next door to a facility that he had rented, and he had 20-odd bicycles, stationary bicycles set up in rows outside his clinic, and his primary treatment for fibromyalgia was exercise. So he would, all his fibromyalgia patients would come in and they'd climb on the exercise bike and they'd pedal away for an hour every evening, and he'd have 30 people pedaling away for an hour, and over time they got slowly better. That's not chronic fatigue syndrome. It will never be chronic fatigue syndrome. In fact, my chronic fatigue syndrome patients whom he actually put on the bicycle got crushed by this, and they would come over to see me. And so I used him as a screening tool. And people that he hurt, I got to see because they had chronic fatigue syndrome. People that he helped perhaps had fibromyalgia. But that doesn't speak to the broader issues of what is exactly fibromyalgia and how does it integrate with chronic fatigue syndrome. Certainly, many chronic fatigue syndrome patients have fibromyalgia syndrome. And I think that there's a lot that could be integrated between fibromyalgia and chronic fatigue syndrome, a lot that we can help with in terms of people with fibromyalgia. But I don't study that condition. These people tend to not gravitate toward my clinic. They tend to gravitate toward people that exercise them. You'll notice that in the definition of chronic fatigue syndrome, exercise makes them worse. That's part of the case definition. So another difference I've observed over the years is that if you read your original fibromyalgia literature, there's almost no significant complaint of cognitive impairment. Or if it was mild concentration problems, and it was number 20 on the list. So significant cognitive impairment is not a feature of fibromyalgia. So if you see someone with significant cognitive impairment, that's not fibromyalgia syndrome. Another difference is the neurologic examination. As far as I know, the neurologic exam of fibromyalgia patients is completely normal. Not so in chronic fatigue syndrome patients. In fact, it's a very rare person that has a normal neurologic exam. Now, it's conceivable that I wouldn't be surprised to find that diastolic dysfunction is an issue in fibromyalgia. There are studies of fibromyalgia where cut downs into the muscle and oxygen probes demonstrate low oxygen tissue, low oxygen saturations in the tissue. So if there's an oxygen transfer deficit or a microcirculatory problem in fibromyalgia, then that might cause muscle pain. And certainly exercise might improve the microcirculation for a variety of reasons. So I think they're overlapping syndromes. They're not exactly the same at their core. In fact, they're, in my view, dramatically different at the core. Sleep disturbance probably is one of the key features of fibromyalgia and one of the key features of chronic fatigue syndrome. And both of them will respond to addressing sleep disturbance. But my core patient population would get creamed by exercising. So that's, they simply don't, in my view, they don't meet the case definition for primary fibromyalgia. They meet the case definition of chronic fatigue syndrome, even though they overlap. This is the Everest 3 study. Is this okay? We'd prefer me to go back to the...
That's good. That's much better.
This is a very key paper called the Everest 3 study. It's a French paper. As the name implies, they took 8 healthy young men and they put them in a hypobaric chamber and mimicked a climb to Mount Everest at different altitudes, 5,000 meters, 7,000 meters, 8,000 meters. They were all in their 20s and 30s, and they echoed them. at each of these different altitudes and recorded the results. And what they recorded were these findings: progressive increase in IVRT, progressive left atrial cavitation, progressive mitral E-to-A ratio decline, progressive pulmonary vein D to S ratio decline. The key feature of chronic fatigue syndrome: progressive increase in pulmonary artery pressures, progressive decline in stroke volumes, increased hyperadrenergic tone. Get this, LV, they described it, left ventricular cavitation. But preserved LV function and left ventricular and diastolic pressure. This list of findings of these healthy young men at 8,000 meters is exactly the findings in chronic fatigue syndrome to a T. So when I read this, I got very excited because I began to look at chronic fatigue syndrome as people on a mountaintop who need oxygen. And all their problem is they can't get oxygen into the system. In the case of the Everest 3 study, when they gave oxygen to these healthy young men at altitude, all of those echocardiographic features completely disappeared within a minute or so. In other words, they were simply manifestations of a low energy state because there wasn't enough oxygen getting into the system at such altitudes, and they were not properly compensated yet at those, because they moved into those altitudes fairly quickly. So this was my instantaneous model of my patients. And you'll notice the oxygen mask. So I said, all I need to do is give these patients oxygen and I'll cure them. I was so excited about this. I couldn't wait to get an oxygen tank into the office. I couldn't wait for the next patient to come in. I slapped them on the table and I gave them 4 liters of oxygen. First I echoed them and they showed the diastolic parameters. Exactly what you see here. Slapped them on the table, put oxygen on them, and was waiting for them to clear, to all these diastolic parameters to completely go away. In fact, they all got worse. They got worse. And which was a very similar moment in my education of this disease. Suddenly, this was not that they can't get oxygen into the system like this. Their problem is they're trying to keep oxygen out of the cell. And you better not try to get any oxygen into the cell or you'll kill them. That's a very big deal, very big transformation of thinking. They're trying to keep oxygen out for some reason. Well, what might the reason be? Well, the reason is that if you can't control oxygen metabolites, such as superoxide, and you can't reduce it down to water, then you have to restrict oxygen throughput. You have to do that. And if you do that, you get an energy problem at the cell level, diastolic dysfunction, not as your problem, but as a solution to the problem. And that changes forever the way you approach these patients. Exercising is not the way to do this. That just drives more oxygen into the system. And you can't give them stimulants to make them simply work faster or work harder. That would just put you in reverse. You have to deal with the underlying defects, which appears to be problems in controlling oxygen metabolism. We call that a redox impairment. This is the IVRT. It's called isovolumetric relaxation time. It looks like this on the echo. It's sort of a diagrammatic. The aortic valve opens, and you get an aortic outflow. Then the aortic valve closes. There's a pause. The mitral valve opens. Blood goes in the opposite direction because the blood's flowing out of the heart to the aorta, but it's flowing back into the left ventricle, so they're going in opposite directions. So this is the mitral inflow. This distance from this high velocity aortic valve closure, which is easy to spot on the echo, and this beginning of mitral inflow is called the isovolumetric relaxation time. It's measured in milliseconds. Normal is typically under 75 milliseconds. And what that is the time it takes for the heart to pump all the calcium out of the myocardial cell to cause relaxation of the heart. And it fills with blood when it relaxes. So this is a measure, in effect, of energy production, because the more energy you have, the faster you pump the calcium out, and the shorter this distance is, the less energy you have in the cell, the slower you pump the calcium out, and the wider this distance is. And in other words, this is a direct measure in in echocardiography of the free energy of the myocardial cell. I can put a number to it, and I can measure this in roughly 30 seconds. So, in the case of the Everest 3 study, when they took these healthy young men up to 24,000 feet, the IVRT got longer because they were dropping their energy out at the higher altitudes because there wasn't enough oxygen getting into the system. And when they gave them oxygen, that IVRT simply went right back to normal as it was at sea level in very short order. In my patients, when I gave them oxygen, this didn't get shorter. It was long to begin with. It got longer when I gave them oxygen. It's like they were toxic to oxygen at the energy level. This is sort of an example of a couple of patients. Again, here's the IVRT measurement right here. Aortic closure, mitral opening, measures 100 milliseconds. Normal should be 75 milliseconds. This is patient number 2. And here's the aortic closure click, and the what is thought to be the mitral opening. I'll get to this particular measurement of the mitral opening is difficult to make. It's subjective in character. It takes really good sonographers to make this measurement reproducible, but we don't really use this measurement to follow people necessarily over time. We use it to follow them on the table in real time. So we make measurements of the IVRT before we do something to them, and then see what happens after we do something to them in 30 seconds to 60 seconds. So all the sonographer has to do is whatever his subjective tendencies are to measure this mitral opening, he just applies the same subjective determination so that you subtract out any subjective error, as long as he tries to make it the same way. This is a patient, an example of the patient who is at baseline, 92 milliseconds between aortic closure and mitral opening. And this is after 4 liters of oxygen. And you notice it went from 92 milliseconds to 111 milliseconds. And after a few more minutes, it goes from 111 milliseconds back to 92 milliseconds. So what we're seeing is a transient loss of energy with oxygen and then a return to baseline. It's never stuck there. It always moves out, they're losing energy, and then they come back. And that's a very important observation because it suggests that this is being buffered. Something is actually buffering this. And that's what really leads to what this probably represents. This movement represents an inability to properly buffer the person's redox state, suggesting the redox mechanism is impaired, so they don't buffer very well. But that buffer impairment simply takes time to recover. It is not a permanent thing on the table, so you don't do. This doesn't cause permanent changes. It's rather transient, and that's an important idea. This is another patient with a baseline of 85 milliseconds, and after 4 liters of oxygen, it jumps up to 98. So we've come to the conclusion after looking at this for a long time. There's evidence of oxygen toxicity by IVRT criteria, which is the opposite of what you see in normal people. In 100% of cases, an N value of greater than 500. IVRT response to oxygen or anything else always returns to baseline, suggesting IVRT is buffered. And since 1 over the IVRT is proportional to the free energy, and free energy is equal to this equation, if you examine each of these elements, G and H and T and S, the only one that is likely to be buffered is the entropy or chaos of the system, which is driven by oxidative stress. You have to buffer the oxidative stress. If you don't, you're going to die. These people will always buffer it. It's just that they take time to do it. Here are some of the complications of this systolic compensation mechanism. We see PFOs, patent foramen valley, in 89% of 60 consecutive patients using bubble contrast studies, which is the gold standard for this. Using the same bubble contrast studies, you might expect this number to be something around 27 or 28%. So these patients have the highest rate of PFO reported in any other illness. The mechanism I'll go over in a second. We also have CCSVI, chronic cerebral spinal venous insufficiency, which is flow reversal, back and forth flow reversal of the deep cerebral veins in 100% of cases. That's going to destroy capillary function in the central nervous system. We're up to about 20 today. We do not see this. And then we have chronic hepatic venous insufficiency. That should be an H, not an S. Chronic hepatic venous insufficiency, also seen in 100%. And right now we're up to about 20 today. Now, this brain flow reversal in the capillary bed and the hepatic flow reversal in the liver is a complication of right ventricular squeeze compensating for diastolic dysfunction. It is probably the most serious complication I've ever found in chronic fatigue syndrome. It will destroy effective capillary function in the brain and in the liver. Results are catastrophic because if you don't have proper capillary flow in the brain, you neither deliver sufficient oxygen and nutrients to the brain, nor do you remove toxins from the brain. Likewise, in the liver, you just knock out important liver function, ranging from detoxification, which will put you at risk for food sensitivities and drug sensitivities. You'll create xenobiotic toxicity of all kinds of things. And the worst of all is your center of gravity for redox control. Primary redox control centers, particularly NADPH production, is in the liver, and that's going to be impaired. So this is an example of PFO. This is a patient which we injected saline bubbles. These are small air bubbles into the vein. They quickly pacify the entire right side of the heart. Because there's a hole right here, those bubbles pass through into the left atrium, and when the mitral valve opens, all the bubbles appear on the left side. These bubbles, of course, go right out the aorta and right into the central nervous system and can be responsible for migraine and also many strokes. Again, we find this in almost 90% of chronic fatigue syndrome. The cause of this is that left atrial cavitation. In the left atrium, when they stand up, when it collapses, there's a pressure differential created across that foraminal valley, and it blows it open, creating this hole again. It was only present when you were born in the utero and closes off in about 75% of cases. In the mechanism, there's rebound filling on the recoil of this massive ejection fraction of the left ventricle, and as it squeezes really hard and then pops back off its rebound, it sucks blood right out of the left atrium, causing a pressure drop that blows right through the PFO. That's, we think, is the mechanism of this, leading to migraine, poor altitude tolerance, many strokes, and UBOs, unidentified white objects on the central nervous system by MRI scan. Chronic cerebral spinal venous insufficiency, a Doppler ultrasound technique used on cerebral venous outflow tracts in the neck and in the deep cerebral vessels, developed by Dr. Zamboni in Italy in 2008. First characterized in MS patients by Dr. Zamboni, later discovered in autism and chronic Lyme disease. Currently observed in 100% of CFS cases to date. Somewhat controversial in respect to invasive vascular interventions, even though such interventions have helped some but not all patients with this condition. Chronic hepatic venous insufficiency, a Doppler ultrasound technique used in hepatic venous outflow tracts in the liver, first observed by me, actually. I know if no one else has even looked for this. Also seen in some patients described as having chronic Lyme disease, currently observed in 100% of CF cases, associated with CCSVI in the brain in 100% of cases. These findings have been confirmed by two ultrasound sonographers, radiologists in California and Italy. I sent them MPEGs of this to confirm their opinion that this indeed is chronic hepatic venous insufficiency. And of course, it's linked, interestingly, to the physiology of pure diastolic dysfunction. This is where it most likely comes from. Because of the big RV squeeze, you get a very high tricuspid regurgitant flow that's passing from the right ventricle through the tricuspid valve, going in the opposite direction of venous return. This pressure pulse, in this case, is almost 30 millimeters of mercury, which is pretty high. That pressure pulse going in the opposite direction needs a return blood flow that's actually low because they have a low cardiac output. And the pressures are relatively low. Therefore, with low return pressures, meaning a high pressure pulse going in the opposite direction, you have potential to reverse the flow of blood. And that's what you see over here. This is one of the early pictures we saw. That red flash is a flow reversal in the hepatic vein. This is two pictures. Now these are MPEGs, and I don't know, I'm not sure I'll be able to run these MPEGs, but if I could, what you would see, these are loops through 3 beats. What you'll see, right in here in this hepatic vein, you'll see blue, red, blue, red, blue, red. That's Doppler shifting. It's supposed to be blue when the blood's moving toward the heart, and it's red when blood is moving from the heart back up into the liver. That's called hepatic reflux. That is not normal. It is never normal, and unbelievably seen in 100% of my cases. The cause of it is that big RV cavitation to compensate for diastolic dysfunction, and a drop in output sufficient such that the venous return is actually low. So you have a low return coming back and a big powerful squeeze pushing blood the other way. That will knock out effective liver capillary function, and a lot of problems will ensue. This is our first attempt to treat this. We're using vasoactive intestinal peptide. This was developed by Richie Shoemaker, who just recently published a paper on the use of nasal VIP, which I'll go over in a second. But this is the TRMXPG pre-VIP treatment, and then 5 minutes post. And what we saw was a degradation of this TRMXPG, which is the pressure pulse causing reversal of flow, which dropped by 8, 22, and 38% respectively in 3 consecutive patients. If you can drop out this pressure pulse, you can actually stop refluxing in the liver. Because what VIP does is a potent vasodilator of the pulmonary vascular bed. So a squirt up your nose will cause the pulmonary vasculature to vasodilate, which means that when the right ventricle squeezes, blood goes out the pulmonary artery rather than back through the tricuspid valve. You're just reducing the pressure so it moves in the right direction, and much less of it goes in the wrong direction, causing these big drop-offs in the TRMXPG. This is what it did to CHVI, or chronic hepatic venous insufficiency. This is pre-VIP therapy. See this big red blotch right there? That's flow reversal. If you watch that in real time, it would be blue, red, blue, red, blue, red. I just stopped it when it was reversing. 5 minutes after nasal VIP treatment, we completely abolished it. No more blue, red, it's just blue, blue, blue. Very impressive and very encouraging, because to date, no one has had any idea of how one might actually reverse either CCSVI or CHVI, which can have tremendous clinical impacts in these patients. So what is vasoactive intestinal peptide? It's a 28 amino acid peptide. It's a member of the glucagon secretin superfamily. It's related, interestingly, to growth hormone releasing hormone. It's produced in the gut, the pancreas, and the hypothalamus. VIP receptors, which are part of the G protein coupled receptor family, is found in the brain, the liver, the lung, the intestines, the T lymphocyte, the heart, the adipose tissue, the kidney, the skeletal muscle, the testis, and the stomach. It's responsible for circadian rhythm, which means that low VIPs, which have been found in CFS patients, will cause day-night reversal in your sleep pattern, which is very common in this patient population. And it will actually knock out appropriate sleep, which, by the way, would have a serious effect on fibromyalgia as well. VIP increases intestinal motility, pancreatic secretion, biliary secretion, and maybe one of the reasons we see reduced biliary tract ejection fractions in the gallbladder in almost every patient. Stomach pepsin secretion inhibits stomach acid, increases chronotropism and inotropism in the heart, and is being looked at for the treatment of chronic heart failure. But most importantly, it's a potent pulmonary vasodilator, FDA approved for that. And if you dilate the pulmonary vascular bed, you promote forward flow and stop flow reversal, which is, we think, the primary mechanism. Certainly explains why it does it so quickly. This is Dr. Shoemaker's paper, which is going to be an important one. He just published this week, actually, using nasal VIP in 20 patients who had what he calls chronic inflammatory response syndrome related to water-damaged buildings, because he's a mold expert. By the way, there is no clinical difference between chronic inflammatory response syndrome due to water-damaged buildings and chronic fatigue syndrome, because we trade patients. I get his patients that he can't seem to fix with mold, and he gets them on my patients because I can't seem to fix them because maybe they have mold, so we keep trading patients. We can't tell the difference between them. This 18-month therapy with nasal VIP corrected numerous inflammatory biomarkers, corrected numerous hormone derangements. This is important right here. Reduced pulmonary artery systolic pressure, increased T regulatory cells, which means it tends to reduce some of the pro-inflammatory aspects at the core of this disease. And get this, enhance the quality of life in 100% of cases. No doubt, if you can reverse flow reversal in the brain and the liver, you will get better.
Is there any hope? Is there any hope that this becoming available to us?
Yeah, yes and no. I'll talk more about that. This is what we think the physiology of these, both CCSVI and CHVA is. Again, due to diastolic dysfunction, the primary compensation mechanism is a big RV squeeze, of course a big LV squeeze too. You see ejection fractions not uncommonly of 80% in these people. And if you squeeze really, really hard, then this little tricuspid valve, which is tethered by very weak papillary muscles, will give way. And when it gives way, a jet of blood from the squeezing right ventricle will shoot into the right atrium, will shoot right up the superior vena cava, and if the return is low, you'll see flow reversal with every beat. In the case of the inferior vena cava, you get blood moving down from that pulse into the liver and cause flow reversal with every beat. We have observed a respiratory component, so that when they inhale, you get greater return, and we see the flow reversal stop because there's enough blood coming back, it can't be reversed. And then on the exhalation, there's a much lower return, and that's when we see the red flash, which is physiologically makes sense. Requirements, therefore, for reflux is a low cardiac output to produce low venous return, excessive RV ejection fraction as compensation for diastolic dysfunction, producing a high tricuspid regurgitant flow. And all of this is caused by diastolic dysfunction, and all of diastolic dysfunction is caused by an energy defect, and all energy defects caused by redox impairment. And we do not know what causes redox impairment. That's where we stop. It's like an onion skin. You keep peeling away the layers. You get down to the basis as far as we can go, but we don't know what causes this loss of redox control. Are viruses linked to chronic fatigue syndrome? And the answer is yes, they are. The first observation of a viral link was made actually in Lake Tahoe during the Ampligen investigations, and it was found that this antiviral pathway, interferon alpha 2,5A synthasase RNA cell pathway, which degrades viral RNA, was extremely activated in all patients with chronic fatigue syndrome in the Lake Tahoe region during at least the early phases of their illness. The finding of this strongly suggests some sort of viral insult, at least in the beginning. This is some of the data from that. I'm not going to explain this except to say this is proof of the tremendous activation of this pathway in these patients. When we sent blood to NIH, what we found in the patient population was what was then thought to be a novel virus called HHV6. We thought it might be the cause of this disease, but then it was found that this virus is found in all humans, typically caught in the first year of life, or the second year of life, and called roseola. But then it was discovered there are two strains, an A strain and a B strain. The B strain is the typical cause of infantile roseola, but the A strain has been primarily linked to HIV. It is easily cultured out of HIV patients and was easily cultured out of my patients in the Lake Tahoe region. This could have been the cause of that high RNA cell activity in the Lake Tahoe region. This is what 6A can do. If you take, using a cell line, if you put a patient's blood in with it, they'll form these big giant cells which literally explode, throwing out hundreds of virions of HHV6 strain A. This was found in about 85% of cases in chronic fatigue syndrome patients in the Lake Tahoe region. It's primary infection is usually with the B strain, but the A strain is associated with AIDS, MS, and chronic fatigue syndrome. It can persist in your entire life in various tissues. It can also integrate genomically into the human DNA and become part of your DNA, which is not a good thing to happen and may be a problem in some of our patients. Other viruses linked to this disease have been the Epstein-Barr virus, causes primary infectious mono, can persist in a number of tissues, can also have genomic integration, and is capable in EBV, but also HHV6 is capable of activating human endogenous retroviruses. Retroviral associations has been long and interesting. First described by Wayne DeFreitas in her study in 1992, finding, using PCR technology, HTLV2-like activity in the blood of CFS patients not found in controls. Her studies, however, were not replicated by others and was subsequently relegated to possibly some error in her technique. Then there was Judy Mikovits finding another piece of evidence of retroviral infection, and also could not be reproduced by others. Although her study is probably a little stronger than DeFreitas's for the suggestion of retroviral infection, but not somewhat unknown as to what retrovirus it might be, because no pathogen was ever isolated. And most recently, published just a month or two ago by Ken DeMellier, is HERV-like integration and activity with producing apparent retroviral proteins in the duodenal biopsies within the dendritic cells. This is an example, this is from this paper, a slide loaned to me by him. And these are biopsies of the duodenum, and these cells that are lighting up in red are dendritic cells by subsequent probing of membrane markers for the dendritic cells, which are antigen processing cells in the duodenum. And what you're seeing in this red is different types of immunoreactivity to antibodies raised in mice or other animals against human endogenous retroviruses, different ones, and they're lighting up. There was no lighting up of any of the controls, which are along the bottom. What's important about this is it may be that there's activation of human endogenous retroviruses in these patients, and that could explain the flirtation we're seeing with evidence of retroviral infection. It may not be an external retrovirus, but rather an internal virus integrated into the human DNA. 8% of your DNA has retroviral inserts dating back from millions and millions of years. What's important about this is they used envelope proteins. See this NV right here? They were lighting up envelope proteins. Well, retroviral envelope proteins contain nagalase activity. Nagalase activity will make your immune system incompetent. The treatment for nagalase elevation is GcMAF. So when we saw evidence of nagalase activity, by the way, that was one of the things that so confused us. We were flirting around with the possible retrovirus infection. We know that retrovirus envelope produces nagalase activity. All all of these patients have naglase activity, but we can't find the retrovirus. But HERDs, human endogenous retroviruses, when expressed, make envelope protein. It could be the naglase activity is coming from the human endogenous retrovirus sequence. And by the way, we're getting close to the end. So we decided to try GcMAF therapy based on this observation of naglase. Naglase is an enzyme activity in the blood that destroys the precursor for GcMAF. GcMAF is very important for immunocompetence. So you can imagine what diseases have naglase activity. The disease with the highest naglase activity is a retroviral disease called AIDS. AIDS patients have the highest naglase activity because they have highly expressed HIV envelope protein, which carries the naglase activity. The next highest naglase activity is in cancer patients. Most cancer patients, if not all cancer patients, have naglase activity. Naglase activity may in fact produce immunoincompetence, which is why cancer patients don't survive. What survival requires is not only getting the core cancer, but also bringing back immune competence. If naglase is elevated, they will never have immune competence, and probably uncurable if you don't get the primary cancer. So, our patient's naglase activity averages that of a cancer patient, approximately 3.5. And we also found that if you plotted the clinical severity, 100 is normal and 30 is intensive care unit. This is, you'll notice that it's a kind of regression line. The higher the naglase gets, the sicker the patients are. By the way, very similar to HIV. You see the same kind of regression curve in HIV. So we're really very excited about this because it meant that by using GcMAF, which is known to knock out naglase, we might be able to restore immune competence to our patients. So naglase activity is immunosuppressive as it destroys the precursor activity of GC protein, limiting the production of GcMAF. Naglase activity is associated with HIV, cancer, and autoimmune diseases. Naglase is associated with CFS and has been linked to the envelope protein of HIV and possibly HERDs coding for envelope protein, which have been observed in the duodenal biopsies of some chronic fatigue syndrome patients, as I just showed you. GcMAF is a partially deglycosylated vitamin D binding protein. Therefore, it's part of the vitamin D axis. And at dinner, I had a discussion with a physician who's interested in vitamin D metabolism. It turns out that GC protein and GcMAF and vitamin D are all integrated in a very complicated and regulated axis called the vitamin D axis. The functional change in the GC protein caused by serial deglycosylation is known as GcMAF and important for activation and competency within the immune system. In vivo deglycosylation occurs by enzymes produced by activated T cells and B cells. So activated T's and B's tend to deglycosylate the vitamin D binding protein, producing GcMAF, necessary for immunocompetence. GcMAF will regulate and expand macrophages, which are the central processing unit of the immune system and capable of modulating and controlling both the innate and cognate immune systems. GcMAF is extremely potent and bioactive at only 20 nanograms, either given intramuscularly or under the tongue. Chemical GcMAF, which is what we used in this study, is made by chemical deglycosylation of the GC binding protein or vitamin D binding protein extracted from human gamma globulin fractions. The methods were we took 25 patients and the method CDC case definition. We got the GcMAF from the Netherlands. We gave it sublingually. We monitored blood chemistry, CPCs, vitamin D metabolism, the VDR polymorphisms, to see if there might be a difference in response depending on which VDR polymorphism you had. The protocol called for administering initially low doses of GcMAF at 20 nanograms every 5 days, ramping up slowly up to 100 nanograms every 5 days. The length of the study was 6 months. Results. These results are reported basically for the first several months of therapy, up to at least 2 months in 19 patients. It was about a 36% had a significant clinical response, even including resolution of symptoms, in at least 2 of the 7 key CFS symptoms that we monitored. And a couple of functional cures reaching a KPS 80, which means they can go back to work. But 21% failed to respond or even got worse on GcMAF. The remainder had sort of mild to moderate responses. So altogether, there was about a 78% response rate, including very good responders and modest responders, and about a 21% non-response rate. We looked at VD polymorphisms. It did seem to be a polymorphism that tended to predict response versus a polymorphism that tended to predict non-response. And I went, and this slide is pretty much about that. We also found that there were indicators of who would respond and not respond based upon calcitriol response. Calcitriol is basically the hormone vitamin D. It's a very powerful hormone, and vitamin D is converted into calcitriol by different types of cell types. But we found that if the calcitriol were either high or low and moved to the mid-range, those were responders. But if the calcitriol stayed low or stayed high, they were non-responders. Vitamin D made no difference. Only the active form of vitamin D seemed to predict response. And it wasn't the pre-treatment vitamin calcitriol, it was the response of calcitriol that predicted the response. This is the clinical assessment we used. We also saw a degradation of metabolite activity, which was nice to see. It tended to drop over time. Not impressively so in the case of chemical GcMAF, but it did drop. This is the calcitriol. I sort of divided it into the best responders were in white. You'll notice they tended to rise from low values to medium values. Non-responders tended to remain the same and not response. And the moderate responders tended to be somewhat high sometimes, but tended to move toward the middle. And this was, I don't understand the reason for this, but this seemed to be a characteristic of response and non-response, is how the vitamin D axis responded to GcMAF. This is just a summary of those findings I mentioned earlier. Then we decided to turn to another GcMAF therapy using probiotic GcMAF, which is not made in a laboratory from human gamma globulin, but made with yogurt and kefir. And this was developed by Marco Ruggiero and his wife at the University of Florence, and they came over because they had developed this probiotic form of GcMAF. And this is the GC protein, which is vitamin D protein, which has 3 sugar molecules, and you can progressively knock off 1 sugar molecule and lop off a second sugar molecule, leaving a final one. You've converted GC protein to GcMAF. The enzymes that do this are interestingly present in probiotics, and which was discovered by Ruggiero, and so he figured out which type of probiotic would produce this type of deglycosylation. He found that a yogurt that he designed would lop off 1 sugar, and a kefir he designed would lop off the other sugar. So we will have the patients make a yogurt, and then with 1 group of ferment that he had developed, and then make a kefir with the other group of ferment, and then mix them together, and you get GcMAF in the probiotic. His sense is that what actually happens in nature is that when babies suckle on colostrum when they're born, colostrum is incredibly rich in GC protein. In fact, it's the richest source of GC protein in nature is in colostrum. So here the baby suckles on colostrum. It goes down into its GI tract where there are organisms called the microbiome, and those organisms can selectively deglycosylate the GC protein and the baby forms GcMAF in its little gut, the GcMAF gains for it immunocompetence during its first days and weeks of life, preventing illness and sickness in infants and death from dysentery. That's how Dr. Ruggiero worked backwards. He said, nature must have already designed this, so I'll just redesign what nature used to make GcMAF, and I'll give it to chronic fatigue syndrome patients. So basically, over on the left side is the yogurt that we made from fresh milk. It contains a ferment capable of knocking off one sugar molecule from GC protein. And this is the kefir made with a different ferment capable of lopping off the second sugar, and the two combined will end up producing GcMAF in essentially a probiotic mixture of yogurt and kefir. We pretty much did the same study, set up the same study in this experiment that we did with the chemical. And what we observed was this study was much more potent, much more powerful in improving clinical status in our patients than the chemical GcMAF. Maybe in some ways it's just simply more potent, it's also more natural. And you'll notice what the target is. The target turns out to be largely the cells in the gut that are referred to, the dendritic cells that have the infection with HERVs. Maybe that's why it works so well, because you put this thing right on where the patient has the biggest problem in the gut. I won't go through all this. It pretty much found the same thing. Although we did not find a VDR polymorphism that predicted success, it didn't matter what their VDR polymorphism was, they would respond. Calcitriol also was somewhat predictive, similar to the chemical GcMAF. If calcitriol was low, went to normal, or was high, it went to normal, they tended to respond. And if it stayed low or stayed high, they tended to not respond. So it's almost as if their vitamin D axis would regulate, they were responders. If it didn't regulate, they were non-responders. We also looked at another parameter. We looked at urinary thiosulfates, which measures the degree of GI tract toxicity. And this is calcitriol data, again, showing, although not quite so striking as the chemical, but the trend is there. The best responders tend to go from low to high, and then the non-responders tend to stay low, and then the moderate responders tend to go from high to medium. But dramatic impact on NAGLase, much stronger dropout of NAGLase, from an average of 3.34 almost back to normal with the probiotic GcMAF. This is the urinary thiosulfates, which indicate levels of toxicity in the gut. And it makes sense that if you use a powerful probiotic, you might improve the microbiome and reduce gut toxicity. And we saw this pretty significantly in these patients. Again, use the same kind of clinical interrogation. Higher numbers mean you're getting better, and lower numbers mean you're getting worse. In the probiotic GcMAF study, we saw fairly similar results. Perhaps a little better, though, in terms of the significant response. Almost 50% had a significant response. About 24% had a sort of modest response, and had a 28% had a modest response, and about 23% failed to respond or even got worse, especially if their calcitriol vitamin D axis didn't respond. And so the final slide, which is really a presentation of what I've learned about GcMAF therapy, is that if you take people with high NAGLase activity who are pretty sick, and you treat them with GcMAF, you will drop the NAGLase. It'll drop from high to slightly elevated to low. And this is the clinical response. As they drop from high when they're sick to medium, they get significantly better. But if you keep treating them and drive this NAGLase from slightly elevated to low, they will turn around and get significantly worse. And that is the take-home message of GcMAF therapy. It suggests to me that the NAGLACE activity may be regulating something, and when it's too high, you don't have an immune system. And when it's too low, your immune system is way too active. And so, and when it's sort of in the middle, your immune system is working the best. So what we do now is if we don't even treat anybody with GcMAF unless their NAGLACE level is above 3. That's in the cancer range. And it will drop it into the 1.5 range. It does never not drop it into the 1.5 range. And then we take them off, because if you keep them on it, they'll keep dropping, and when they drop down in this lower range, it's like their entire immune system blows up, which suggests that this NAGLACE may be acting as a regulator. Again, since NAGLACE activity may be an envelope protein from a human endogenous retrovirus sequences, it is known that human endogenous retrovirus sequences participate in immune regulation. As a matter of fact, they're responsible for pregnancy in the sense that the female's immune system is downregulated during pregnancy to prevent attacking the fetus. So it's possible what we're actually watching is the regulation of the human endogenous retroviral sequences and its envelope protein expression. And treating high is good, but you need to stop right here, or it'll get worse. And that's sort of the take-home message for GcMAF. And that's it.